Okay. And do you are you compliant to your medication?
Yes, doctor.
Do you use any over-counter medicine?
No,
I want to ask you some private question. Do you use any recreational drug?
no, doctor.
Any allergy to any medicine?
No.
Okay. Mr. Hussam, do you have any tummy pain?
Sometimes, doctor, when I have fast food or heavy meal.
You have tummy pain?
Yes, sometimes if I take fast food or heavy meal.
Okay. Where is this site exactly? All over your tummy
Mainly
or
in
in specific?
mainly in the center of my tummy.
Uh-huh. And is it relieved by any position? I mean that you try to
Just
be in
only
any
when I
position.
take the omeprazole, this is before the meal. Yes, it goes is not it continues me a lot.
Mhm. And any change in your bowel habits?
No, it is fine.
Any throwing up of blood?
No throwing up of blood or any other material.
Okay. Do you notice that your stool become dark or black?
No, it's normal.
Do you have any change in your water work?
No, it's fine.
Mhm. Do you have any history of trauma to your chest before?
No, doctor. No.
Mhm. Can I know what's your job?
I am working as a secretary in one of health clinic.
Mhm. And you told me that also you have you feel this chest pain when you have heavy object, when you take heavy object.
Yes, doctor.
Um,
Observed in one occasion. This is about 4 weeks ago. I was changing the furniture in my house, and after I leave this heavy object, I feel the pain in my right side of chest.
do you notice that all these attack of chest pain are similar, the same nature of the chest pain, or there is difference in each of them?
There is difference, doctors, but more or less the duration is 5 to 10 minutes. But the character and the what associated is sometimes different.
And what about the last chest pain, the nature of last chest pain?
The last, it is burning in nature and continue for 10 minutes and associated with short press and sweating.
Uh-huh. Okay. Do you have any headache?
Occasional headache, doctors, maybe once per month, and it is released by paracetamol.
Okay. Is it increased with coughing and coughing or bending forward?
The headache, no.
Any abnormal sensation in any parts of your body?
No, doctor.
Any weakness in any part of your body?
No.
Can I know what's about your family history? Any family history of similar condition or heart disease before?
My dad, just 3 years ago, he died from heart attack. My mom, she is taking medication for high blood pressure and high blood sugar.
Mhm. At which age he died, your father?
75.
Okay. And any family history of sudden death?
No, doctor.
Any family history of clot before?
No, I don't know exactly, but as I know, there is no any a family history of clot, apart from my dad, which is 3 years ago passed away from heart attack.
Any family history of peptic ulcer disease?
No, doctor.
Okay. And do you smoke?
Yes, doctors, I'm smoking as the doctor advised me, but it is difficult to me. I minimize just only the number. I was used up to 1 pack per day. Now I'm using up to 6 to 7 cigarettes per day.
Yes, Mr. Hussam, my advice for you to stop smoking as it has a bad effect in your health generally. Is
Yes,
that
doctor,
okay?
thanks.
Do you drink alcohol?
No,
Okay. Can I examine you?
sure, doctor. Tell me which part
I
or
want,
which issue. I want to tell you the sign.
okay. Um, yes, I want to start from the hand to see if there is any sign of anemia, any in the hand, I mean, and the pulse. Also want to
The
check the blood pressure.
hand is totally normal. No, any. Signs of anemia, no clotting, and the pulse normal, 72 per minutes, regular, bilateral, equal, sinus, no special character.
Okay, then I want to check the patient pallor and jaundice and
No pallor, no jaundice.
any neck swelling
No any neck swellings. If you mean
and
goiter, no. No palpable lymph node.
I want to check if there is any lymph node.
No palpable lymph nodes.
Okay. Then I want to check the cardiovascular examination of the patient if there is any first heart sound, second heart sound, apex, and
The
if
heart
there is any
sound,
murmur.
first and second, both normal, no additional heart sound, and the apex in place in the fifth intercostal space mid-clavicular line. No any murmurs.
I want to assess the site of this chest pain. If I press any tenderness,
No local tenderness, but the site all over the right side of the chest.
all over the right side.
Yeah.
Okay. Then I want to examine for any added sound in the chest to assess the air entry.
For air entry, both is normal, no difference between both sides, and there is no any additional lung sounds. So the lung are clear.
I want to assess if there is any epigastric tenderness.
No tenderness in the epigastric area.
Any lower limb edema.
No pedal edema.
Okay. So, Mr. Hassan, do you have any joint pain?
No, doctor.
Any skin rash?
No.
Any mouth sore?
No.
Okay. Any muscle pain?
No.
Okay. Any difficulty when you get from sitting to standing position?
No.
Okay. Uh, can I know what's concerning you?
What is the cause of this chest pain? And I afraid to have heart attack like my dad.
I appreciate your concern, Mr. Hussam. From what you said to me and after examining you, I have a lot of possibility in my mind that may be the cause for your chest pain, as there is different nature and different presentation for your chest pain. So for that, I need now to keep you in the hospital to do for you some raising of your heart and imaging of your heart to exclude serious condition like heart attack. And after that, we will assess you by the heart doctor, by the gut doctor, to give you the appropriate treatment for your condition.
Okay, doctor. Thanks a lot. So suppose now time is out. If there is enough time, do you think any other area to cover in history or any part of the system to want to examine? If you are happy and satisfied, that's fine.
Yes.
Okay. So, Dr. Reem, you answer the patient concern. He has different possibilities, and you wanted to admit the patient. Why the cause of admission? Why you wanted to admit the patient?
Yes, the patient has a history of chest pain, which is not typical chest pain, but
Mhm.
he has history of shortness of breath, and he has risk factor like high blood pressure, and he has family history of heart attack. So for
Mhm.
that, I need to rule out heart attack or cardiac cause.
So the main
Definitely,
reason
I
of
need.
admission
Uh-huh.
is to rule out a coronary heart disease or ischemic heart disease.
Yes.
Okay, that's fine. What other possibility you are thinking about?
Mhm. I'm thinking about could be gastritis, but or gastroesophageal reflux disease. But again, is that he deny any history of heart pain or acid press sensation.
Mhm.
Also, I'm thinking about trauma that he has sometimes has this chest pain after lifting heavy object.
Mhm.
But again, is that when I did examination, I didn't find any tenderness in the side of chest pain.
So you put the second possibility could be peptic ulcer disease. Second one, it could be musculoskeletal disease, causes of chest pain.
Yes, it could be, I mean, cost trauma. Also,
But
I'm
there is
thinking
no
about
history of
cost.
trauma. He denies no history of
I
trauma.
mean,
He just only leave heavy object.
yes, I mean that lifting heavy object.
Okay.
I mean muscle strain. Yes.
So in order of frequency, you put ischemic heart disease must be ruled out. Number one, that's why you wanted to admit the patient. Number two, as a possibility, gastric reflux or peptic ulcer disease. Number three, musculoskeletal disease. Any other differential in your mind apart from these three?
Yes. Also, I'm thinking about costochondritis, but
Which it will
there is
be
no
part
chest.
of musculoskeletal. Okay.
Yes.
So you admit the patients. What do you uh, do as a follow-up or investigation, further workup?
Yes. This patient, I need to assess his vitals regularly. Then after that, I need to do for him ECG and echo
Mhm.
to rule out ischemic heart disease. I need to do D-dimer, although he has low probability of PE, but I need to do D-dimer to rule out BE.
So
Also,
one
apart,
of
I
your
mean that apart
one
from
of your
basic,
differential diagnosis, it will be BE.
yes, I
Okay.
need to rule BE, yes. Okay. And I need to do about, I mean that apart from basic investigation, I want to do ECG, echo, D-dimer, and cardiac enzyme, random blood sugar,
Mhm.
hemoglobin A1C. Also, I can do chest X-ray for this patient.
Okay. Okay, that's fine. So I will come to my comment. I don't know. There is a reflection of the sound. My sound is clear.
Yes.
Okay. What you did, typically your history is very fine. Don't know.
Sorry,
There is
Dr. Imad, there is an
yes.
echo.
There is echo sound. I don't know what has happened. Uh, Now is okay.
Yes.
Okay, fine. Dr. Reem, what you did exactly as a history, very good in the history taking. You analyze the chest pain in a proper way. You cover, I think, most of the systemic review, whether the cardiovascular or the chest, GIT, neuro, and all of that. Apart from that, as a part from the cardiovascular, to ask about any history of syncopal attacks or dizzy spells, also to be asked like that. Otherwise, you cover the history, family history, and all of the other related history in a good. Whatever also during physical examination, it is good. So as a general and the local, mainly in the local here, cardiovascular and the chest, and the abdomen also if you do it, if there is enough time. Very important regarding this issue. One of the common scenario, which is chest pain, and the patient in front of you is the normal patient. That's why one of the expected question from the examiner, what did you find? So if this case came to you in the exam, the first question will be asked from the examiner, what did you find? Means what's your physical finding? Of course, the examiner observing you which area you are covering and which area you are examining. And as in this patient, nothing abnormal. Apart from he mentioned to me the blood pressure a little bit high. But all the other general and the local examination totally normal. So be away from the like this And if you elicit any wrong finding or any wrong sign, suppose if you said there is S3 gallop, suppose if you said there is basal crackles, suppose you said JVB is rest, or if you said lower limb edema. So if you elicit any sign which is not there, it will be against you. This is very important in like these cases. So like these scenarios, it's mainly how to take a proper history and how to analyze the main symptoms, plus the systemic review, and at the end to reach for the final diagnosis or the most likely or probable diagnosis. Of course, as Dr. Reem said, in this specific patient, the chest pain, it is not typical chest pain. So it is not typical as a site, it is mainly in the right side, but the typical site, which is retrosternal, which is not in this patient, is not typical in character. Sometimes, as he said, dull aching, burning, heavy. So it is not typical character. The third issue is the only one which is regarding the duration 5 to 10 minutes. You know the ischemic chest pain, usually in minutes. Ischemic chest pain, never to be in second, never to be hours. Means to rule out ischemia regarding the duration. Ischemic chest pain, never to be second. If the patient said just only few seconds and it goes, never to ischemia. If the patient, he said the chest pain continue for 6 hours or continue for 1 day without interruption or without relieving, never to be ischemia. So the ischemic chest pain as a duration from the typicality, usually minutes, which is from 2 minutes, 5 minutes, up to 30 minutes. So the patient not typical as site, not typical as a character, but only regarding duration. He said the last 2 occasions associated with short oppress and sweating. This associated 2 symptoms is very significant for any chest pain, even if this is atypical chest pain. So ischemic heart disease or coronary heart disease must be ruled out in this specific patient because of 2 issues. The last 2 occasions, they have some typical symptoms or associated symptoms, mainly short oppress and sweating, plus the duration, which is 5 to 10 minutes. The second issue is the patient has other risk factors. He is smoking, dyslipidemic, positive family history of ischemia. So these 3 or 4 issues giving high risk possibility to rule out ischemic heart disease. As Dr. Reem said, very important when you answer the patient concern, put your plan to the patient. You wanted to admit or no need to admit. It is very important the examiner wanted to listen from you. What's your plan after you said the first possibility? In this specific patient, I have different possibility, or ischemic heart disease, as you said, this is the first one to be ruled out. That's why I wanted to admit you or observe you in the hospital. But in this specific scenario, if you say to the patient, no need for admission, or I will follow you in the outpatient, you will be right as a decision or regarding the management plan. So when you answer the patient concern, put the management plan in a very short way and say to the patient that, and the examiner are listening to you for that. So the patient need to be observed and admitted because I wanted to rule out ischemic heart disease by doing ECG and the cardiac enzyme. What if the examiner asking me, suppose you did the first ECG and the first cardiac enzyme, both are normal. What is the decision? Is to discharge the patient home or still what's the next step? Once you suspect ischemic heart disease, even though if the chest pain is atypical, and even though the first ECG or the first cardiac enzyme came negative, keep the patient at least for 24 hours in hospital. And do for the patient serial ECG and the serial cardiac enzymes through the 24 hours. If all the ECG and all the cardiac enzymes within 24 hours came negative, of course, this is not ischemic heart disease. And you can discharge the patient safe, and it could be other possibilities, whatever it is. So This scenario mainly how to analyze chest pain from the typicality and what associated symptoms and what is the next plan. If you not keep ischemic heart disease in this scenario, you will be away from the scenario. If you said it is mainly peptic ulcer disease or gastroesophageal reflux, if you said it's mainly musculoskeletal because it is related to lifting heavy object, so you will be away. So the first possibility is ischemic heart disease. Why? Because the patient has the last two occasions typical associated symptoms with the chest pain. And the patient has other risk factors, hypertension and dyslipidemia, smoking, and the positive family history. The other possibility is peptic ulcer disease or musculoskeletal disease. It will come the second and third times. This how to think about the scenario. So the patient need to be admitted. I will do serial ECG and serial cardiac enzyme within 24 hours. Of course, if came negative, I can discharge the patient safety for further workup as further differential diagnosis now, which is not serious. So put in your mind the most common disease and the serious disease to be ruled out in any differential diagnosis. Another important point in this patient, as I'm telling, when you examine the patient, examine the specific general, you should examine the general, looking for pallor, jaundice, lymph node, mouth ulcer, and pedal edema as a general look to the patient, then to the specific system. Mainly the specific system, of course, in this patient, the heart. I should examine the heart sound, and I rule out any specific murmur, and if the patient in failure or not in failure. Looking for the GVB and the pulse and all of this as a vital is very important. Examine the back of the chest only for the breath sound, if there is chest is clear or there is any basal crackers, especially if the patient in heart failure. Abdominal exam to do this because the patient has tummy pain. Yes, I can even palpate the patient just on for superficial palpation and deep if the patient has organomegaly. Neuro, of course, not related in this patient, and other system also is not related in this patient. But the most important, to be self-confident if the examiner asking you, and of course he should asking you in this specific patient, what did you find? Till there is no any abnormal physical finding apart from high blood pressure. Full stop. Because if you elicit any sign which is not there, it will be against you and wrong. The examiner, he will catch you why this sign and what is the cause of that and so on so, and you will it will be a part of tricky issue in a normal patient. So some of the scenario in the center, they have the scenario and they can bring any patient from the ward or any porter or cleaner or somebody and make the scenario for this a specific patient. Be aware from this tricky because it's very, very important. So to manage the time is very important. To take the full history is very important. And to do the physical examination and be sure and be self-confident not to elicit any wrong signs. Very, very important in this specific scenario. Of course, after the doctor said to D-dimer, if you think pulmonary embolism in this patient, I can say it is not here a part to diagnose pulmonary embolism. But another similar scenario, pulmonary embolism here is not suspected at all. I will not put as a differential diagnosis. That's why no need for D-dimer, and there is no need or to do lung scan or ventilation perfusion lung scan. No need in this scenario. When? Because this is a male patient, there is no any history of hypercoagulable state. I don't know, Dr. Reem, I forget you ask about travel history or no. It's important here to ask about travel history. If there is any recent travel history, if you are thinking about pulmonary embolism or others. But if the same scenario, but mentioned to you, it is a female and she is married or get pregnant or she taking oral contraceptive pills or there is a history of long travel, and I put in my mind the pulmonary embolism, of course, as a cause of chest pain, of course, I will put the first possibility here, pulmonary embolism and not ischemia. So the same scenario, it can have the chest pain, but just only the sex is changing, and the patient, she is married or a childbearing period, she using oral contraceptive pills, or she has history of miscarriage and so on. So I will put the pulmonary embolism the first possibility if the scenario came like that. But here he is a male patient, no history of long travel, no history of hypercoagulable state. That is why pulmonary embolism is a way or not a one of differential diagnosis. I think Dr. Reem, you did it very well. I am listen now to for any comment. Start from Dr. Reem and then we'll take other colleagues. Yes, your rule now, Dr. Reem.
Yes, thank you, Dr. Imad. I think about BE. If I mean that no need to rule out BE, even by investigation. I didn't put in the differential, but if any
Once
patient
it
came
is
with
okay,
chest pain, no
no
need
need
to
to
do
do
D
the
dimers.
dimers.
No need.
Yeah.
Okay. Thank you.
Other colleague, please.
Doctor, I have a question. The gentleman had a tonsillectomy. I would like to know that when was it done, and then recent surgery. Then I can suspect PE.
Yes, but this is the tonsillectomy, he said, during one at the age of 5. So long time not related to the scenario at all.
Okay. Thank you.
Hello?
Yes, doctor.
Hello?
Yes, doctor. Go ahead.
Yes, good evening, sir. Thank you for the session. I just heard you mention Daima. Hello, can you hear me?
I am hearing sound is very
Am I
low, but
audible?
just raise your voice, please.
Yeah.
Waiting for connection.
Hello?
Okay.
Can you hear
Sorry,
me?
sorry, doctor. Just I will
Hello?
mute one doctor. Yes, go ahead, please. Okay.
All right, thank you. I just heard you mention, sir, that you said the D-dimer may not be necessary in this scenario. Please, I don't understand why. I need more clarification, sir.
Yes, doctor.
Thank you.
D-dimers, if you are suspecting pulmonary embolism. Okay, in that specific patient, he is a male patient, middle age. There is no any history of hypercoagulable state, no history of long travel, so no precipitating factors, and this is not the typical scenario of pulmonary embolism. Okay, but the reverse it could be if this patient, female patient, middle age, a childbearing period, taking contraceptive pills, there is history of miscarriage, or there is history of long travel, of course, pulmonary embolism, it will be the first possibility. But in this specific patient, pulmonary embolism is not a possibility. Why? Because this is not acute chest pain, it is subacute, 6 weeks patient, although it is associated with some short of breath in the last 2 occasions. So pulmonary embolism here is not the possibility. That's why no need to do the dimer. So, but ischemia, yes, of course, to be ruled out. But in female, we cannot say my childbearing area, ischemia is the first possibility. Pulmonary embolism, it will be the first possibility. You get my point?
Okay. Yes, sir. Thank you so much, sir.
Okay. So again, the same scenario. It can came, but just only in front of you, it will be a lady, a childbearing period, patient taking contraceptive pills, patient she has miscarriage, patient she has long travel history. Of course, pulmonary embolism, it will be the first cause of chest pain in this lady, not ischemia, because ischemia is not common in this childbearing period in female, but pulmonary embolism, it will be the first top possibility. Okay. Any further concern, please, or
Sir,
question?
can I ask one question?
Sure, doctor.
Pulmonary embolism will come like this 10 minutes pain and then will go back. It will persist, I think.
Pulmonary embolism, is what, doctor?
It will not come and go. It will either persist or it will go.
Very good. Yes, pulmonary embolism, it is something acute. unless it is acute on top of chronic issue,
Yeah.
which is totally different in this. It is not here in scenario at all.
Yes.
Okay. So as you know,
Yes.
Doctor,
yes, doctor.
Doctor, please, what against diffuse esophageal spasm here?
Diffuse esophageal spasm. What you mean by diffuse esophageal spasm?
Um, like a spasm of esophagus and with neck pain also.
But there is no any neck pain. There is no any radiation of the pain.
No, no,
But you
no.
can say
I
it
mean,
as a
it will make also chest pain, like
no
patient
chest pain.
suffering.
There is multiple causes of chest pain, but after you rule out ischemia in this patient, you can say it could be gastroesophageal reflux or other peptic ulcer disease. You can say other abdominal issues like cholecystitis, pancreatitis, many causes of chest pain it can happen, or musculoskeletal, or at the end, if the patient has mood disturbance or has stress, it could be psychological. But never to say psychological as a top or in the middle of the list, unless you rule out all organic issue. You can say it is pleurisy. You can say it is pericarditis. But in this patient, there is not related to the breeze and the chest pain. Also, there is no any history of flu and something like that to put pleurisy or pericarditis as a cause of chest pain. Okay, doctor?
Sir, I have a question. Can I
Yes,
ask?
doctor. Sure.
Okay, sir. Thank you, sir. Sir, in this case, as we are thinking about the ischemic chest pain, so is it necessary to ask about the any contraindication to antiplatelet medication? And if it is, then how we can ask?
Yes, of course, the doctor, she said there is any black stool, the patient he has any history of bleeding per orifice and all of this, or the patient has ecchymosis or trauma or something like that. This is the questions I wanted to ask if I'm thinking about ischemia and I wanted to give the patient antiplatelets or even if you wanted to give low molecular weight heparin and so on. So this is a question. If the patient has any bleeding tendency or he has any bleeding from any orifice, do you have any black stool? Do you have any blood in your urine? Do you throw up some blood? Do you cough up blood? And so on. This is a question I wanted to ask. Or do you have any bruises? Or do you have any pleuge discoloration in your body? I wanted to ask like that. This is how to ask about bleeding disorders or bleeding tendency for the antiplatelet if you wanted to give.
Thank you, sir. And
Okay.
another question regarding if we suspect about this deep vein thrombosis, then in examination, should we check the leg for any swelling? Is it important?
Of course, you should examine the leg as for pedal edema. But if the patient said, I have some skin rash or some bruises or something, you should examine, of course. If you ask that and the patient said, I have some skin rash or bruises here or there, you can check. You can check that, of course.
Okay, sir. Thank you, sir.
Okay. Any further inquiry regarding this scenario, please?
Can I ask a doctor a question, please?
Yes, go ahead. Yes.
Should I also analyze the cause of refractory hypertension here? Can I suspect, for example, coarctation or pheochromocytoma? And should I analyze them and make the workup for
Of
them?
course,
Or
it
no
will
need?
appear when you take systemic review, all of this data, it will come with new analyze systemic review. Okay. You ask about palpitation, you ask about headache, you ask about any sweating, if this is comes in episodes to say this is a refractory hypertension or secondary hypertension due to pheochromocytoma or coarctation. Of course, it is not a coarctation because the blood pressure and the pulse is equal in both sides. So coarctation never come in infrequent over 6 weeks. That's one. The pheochromocytoma, it is not an episodic headache or palpitations or tremors or something to suspect pheochromocytoma. So it is not related, but it will come in your mind when you cover the systemic review. Okay?
Okay. Yes. Thank you, doctor.
Thanks. Okay. I think some of the colleagues just joining now. Time is out. Thanks for all of you. See you inshallah next week. I don't know, most probably we can say I do my best to cover next week for communication or another history, but we'll see. If it's not on the Tuesday, might be in Wednesday. I will mention and remind you before. See you inshallah next week for another sessions, and best wishes and good luck for all of you.
Thank you very much.